Welcome to the Radon Smart Review Head and Neck Cancer series.
Today we're tackling a really advanced and, frankly, often intimidating topic.
Yeah.
We're talking about planning radiation therapy for a head and neck cancer after a complex post-operative reconstruction.
Yeah, this is way beyond the standard cases. We're going to get into the details of these really complex oral cavity scenarios, things involving soft tissue flaps, osseous flaps.
Like the fibula, yeah.
Exactly. And the big challenge of hardware artifacts, and maybe most importantly, navigating that very difficult trade-off with osteoradionecrosis risk.
Right. I mean, what do you do when the target is the organ at risk?
That's the core question. So our mission today, and this is absolutely critical for any resident who's getting ready for oral boards, or really any clinician who's managing these tough cases, is to break down the principles that guide your target delineation and your dose optimization when the anatomy, looks nothing like it did on the pre-treatment scans.
That's a great way to put it. So, to really ground this conversation, let's start with a specific clinical case. The details here are what drive every single decision we're about to discuss.
Agreed. Let's set the stage. We have a 58-year-old man, and he presents with a right oral cavity cancer. The pathology is a T4, a right floor of mouth squamous cell carcinoma. And here's the key finding. It's invading into the cortical bone of the mandible.
And that bone invasion changes everything. It means this isn't a small surgery. He needed a major intervention, a composite resection.
Can you walk us through what that entails?
Sure. So a composite resection here means they took out a segment of his mandible. That's the segmental mandibulectomy. They also did a complete right neck dissection, levels 1 through 4.
And then they have to reconstruct that huge defect in the jaw.
Exactly. And the surgical team used the workhorse for these bony defects, which is a fibular free flap. They basically take a piece of the fibula from the leg with its blood supply and move it up to create a new jaw, securing it with a big titanium reconstruction plate.
Okay, so surgery's done. Now the final pathology report comes back, and this is really the inflection point for how intense the post-op treatment needs to be.
It is. The final path is pathologic T4A, and crucially, pathologic N3B.
N3B, let's break that down.
He had 3 positive nodes out of 22 taken, all on the ipsilateral side. But the single most important adverse feature, the thing that drives the N3B staging, is extranodal extension, or ENE, which they found in one of those nodes.
And the margins.
Fortunately, the margins were negative at 3 millimeters. But that ENE, that's the game changer.
Right. That finding alone dictates the need for a concurrent chemotherapy, and it sets the highest dose requirement for our radiation plan.
Precisely. So here's our challenge, the
Yeah.
one we're going to spend the next half hour or so solving. This patient absolutely requires post-operative chemoradiation because of these high-risk features.
Yeah.
But we have to deliver that dose and deliver it reliably around this big titanium plate and this new transplanted fibular neomandible.
So the question is, how do we make sure we get robust curative target coverage while trying to minimize the late toxicity in an area that's, already been through this massive surgical trauma?
That's the million-dollar question. And before we even think about opening the treatment planning software, we have to be absolutely rock solid on the oncologic strategy. The staging, the need for chemo, the field design, all of that has to be perfect.
Okay, let's start there. The requirement for concurrent chemoradiation, you said it's mandatory because of the ENE. What's the fundamental trial evidence for that?
Yeah, that decision is really anchored in 2 landmark trials, RTOG 9501 and EORTC 22931.
The ones everyone needs to know for boards.
Absolutely. They established the benefit of adding concurrent cisplatin-based chemotherapy to post-operative radiation for patients with high-risk features. And ENE and positive margins are the 2 highest risk features there are. Given the ENE in our patient, we ethically cannot withhold chemoradiation. It is the non-negotiable standard of care.
Got it. So chemo-RT is a definite. Now let's talk about the field design, specifically the nodal coverage. His positive nodes were all on the right side, the ipsilateral side, but his primary tumor was in the floor of mouth, which is a midline adjacent structure. Why is bilateral elective coverage the standard here?
The rationale for that is all about the lymphatic pathways of the oral cavity. The floor of mouth has this incredibly rich, interconnected lymphatic network.
So it drains everywhere.
It can, yeah. It often drains across the midline, even if the tumor looks like it's only on one side. So if your primary tumor approaches or crosses that midline, the risk of having subclinical microscopic disease in the contralateral levels, specifically 1B and 2, is just too high to ignore. It's usually in the 10 to 15% range.
And leaving that untreated would be
An unacceptable geographic miss. a potential failure.
And I imagine the N3B designation just reinforces that decision.
Absolutely. Pathologic N3B represents a really substantial tumor burden. It signals aggressive biology. So the bilateral elective coverage is justified by the primary site's risk, and it's doubly justified by the extensive nodal disease we already found on the ipsilateral side.
This brings us to a really crucial staging principle, and it is a massive trap on any board review exam. It's the ENE rule for oral cavity cancer. Our patient had 3 positive nodes. Without ENE, that might be N2B, but that one node with ENE changed everything.
This is a core principle from the AJCC 8th edition, and it's specific to oral cavity primaries. The rule is this: any pathologic extranodal extension, or ENE, upstages the disease to PN3B.
Regardless of any other factor.
Regardless of the number of positive nodes, the size of the nodes, or the laterality, it doesn't matter.
So an examiner is going to try and distract you with the node count, right? They'll say 3 nodes trying to lead you down the path to N2B or N2C.
That's the classic trap. But if ENE is present in an oral cavity primary, you have to ignore those traditional criteria of size and number. You have to flip the logic. ENE is PN3B.
And what's the biologic reason for that?
It signifies that the cancer is broken through the capsule of the lymph node and is actively spreading into the soft tissue of the neck. That is a much, much more ominous prognostic factor than just having a large node or multiple nodes.
So a good mnemonic to have in your back pocket.
The one to internalize is simple. For oral cavity, ENE equals N3B. Just memorize that phrase. It will save you from the trap every single time.
Okay, so staging and field boundaries are set. Now let's get into the nitty-gritty of the simultaneous integrated boost, or a SIB, fractionation scheme. This is the board-safe, standard approach for high-risk post-op disease, and the specific doses have to be known precisely.
Right. We prefer the SIB approach because it shortens the overall treatment time compared to, say, a sequential boost. And that's important because it minimizes the impact of tumor repopulation.
A huge radiobiologic concern in these rapidly proliferating head and neck cancers.
A major concern. So for this plan, we are committed to a 33 fraction scheme. That really helps balance the dose delivery with patient compliance and trying to meet our organ at-risk constraints.
Okay, walk us through the why of the 3 different dose levels, and let's focus not just on the total gray, but the per fraction dose, because that has real radiobiologic implications.
Absolutely. So the highest dose level goes to the highest risk area, which is the ENE nodal bed. This volume receives 66 gray and 33 fractions, which calculates to exactly 2 grays per fraction.
And that standard 2 gray per fraction is our anchor here. Why that specific number?
It's based on decades of dose fractionation data. For high-risk, potentially bulky microscopic disease, like in an ENE bed, that 2 gray fraction optimizes the therapeutic ratio. It's based on the typical alpha-beta ratio for squamous cell carcinoma, which we think is around 10. We really need that full 2 gray per fraction to maximize tumor cell killing in this highest risk volume.
Okay, so 66 and 33 for EN. Then we step down to the intermediate dose level. This covers the rest of the surgical bed, that critical flap interface, and the dissected ipsilateral nodal levels, 1B through 4.
Right. That volume receives 60 gray in 33 fractions, which gives you 1.82 gray per fraction. And that slight reduction in the per fraction dose is radiobiologically significant.
How so? Why 1.82 instead of just keeping it at 2 gray?
By dropping the dose per fraction slightly, we can often spare critical structures a little bit better, like the parotid or the pharyngeal constrictors. But really, in the post-op setting, it's primarily designed to mitigate late effects. We're talking fibrosis, xerostomia, while still giving an excellent controlling dose to a zone that has a lower but still very significant risk. 60 gray total is plenty for microscopic control.
Makes sense. And finally, the lowest dose level, the elective bilateral neck, including the contralateral levels 1B through 3.
This is our lowest risk area. It receives 54 gray and 33 fractions, or 1.64 gray per fraction.
And that's enough to sterilize potential microscopic nests of cells.
Exactly. That dose level is sufficient to eradicate subclinical disease in true elective nodal volumes, while providing the maximum possible sparing to the contralateral side. We're trying to preserve as much salivary function as we can and minimize neck fibrosis on that side. The key principle across all 3 doses, though, is maintaining that consistent 33 fraction delivery time.
Okay, we have our doses and our volumes locked in. Now, for the really challenging part, the planning physics and the contouring challenges that this reconstruction introduces, let's start with the sim and the imaging.
So the setup is pretty standard. Supine position, a rigid 5-point thermoplastic mask to keep everything still, and usually neck extension. But we have to acknowledge the clinical reality of this case. The patient had a segmental mandibulectomy.
Which means
Yeah.
what for the setup?
It means that using a traditional bite block to separate the maxillary and mandibular arches, to
Yeah.
push the tongue down and away from the high-dose zone, that may be severely limited.
Because of trismus or just the bulk of the new flap?
Precisely. You might have trismus, or the fibular flap reconstruction is just so bulky there's no room. So we have to be pragmatic. We have to ensure the setup is reproducible, even if we can't get that ideal organ at risk separation that a bite block would give us.
For imaging, we absolutely need a CT with IV contrast. But you mentioned a critical request for the CT tech, the metal artifact reduction, or MAR algorithm.
That is the single most important instruction you can give the CT tech when there's hardware involved. We know that titanium plate is going to generate horrible streak artifact. We have to try and mitigate that noise right from the image acquisition stage.
And what's the necessary partner to that CT, especially for delineating the soft tissues?
Rigid MRI fusion is non-negotiable. It's not an option. It's a requirement.
Why is it so critical?
Because the MRI gives you superior soft tissue contrast, and this is the key. It is completely unaffected by the titanium hardware. So we use the pre-op MRI to see where the original tumor was, and we use a post-op MRI, usually T2 sequences, to delineate the current soft tissue contours. This is essential because the CT image quality near that plate is going to be terrible.
And you have to really verify that fusion.
Oh, absolutely. You have to take the time, slice by slice, verifying landmarks. The new position of the fibula, the post-op edema, it's going to drastically alter the anatomy you're used to seeing.
Okay, let's talk about actually identifying the flap on the scan. Why does the type of flap soft tissue versus one with bone matter so much for our planning?
Flap identification is central. We need to understand its composition for two main reasons. One, for target contouring, and two, for dose calculation accuracy. A bone-containing flap, like the fibular free flap in our case, is inherently heterogeneous. It's got bone, muscle, soft tissue.
Right, versus a pure soft tissue flap like a radial forearm or an ALT flap.
Exactly. Those will have different densities, and that's going to have a different impact on how the radiation dose is absorbed and transmitted through the tissue.
You mentioned a pearl for recognizing the flap on CT based on density discontinuity.
Yeah. You have to look for that sharp boundary. If the transplanted tissue is a soft tissue flap, like an ALT from the thigh, it often brings a lot of fat with it. So you'll see this fat density, which can be as low as -50 Hounsfield units. Native tissue is much denser, 0 to 70 Hounsfield units. That sharp change in density is the telltale sign of the flap boundary.
So if the surgeon didn't place any clips, we're basically hunting for a subtle change in the grayscale on the CT.
That's exactly what you're doing. And let me tell you, surgical clips placed right at that flap native tissue junction are an absolute gift to the radiation oncologist. Always check the op note and look for them on the CT. They confirm the location of that seam that we absolutely must cover.
This brings us to the critical contouring principle. This is the core of this whole discussion, and it's emphasized by groups like GORTEC and HNCIG. Why is the interface the single most critical area?
The flap native tissue interface is. It's the biological seam where the highest likelihood of residual microscopic disease meets the most compromised tissue. It's where the vascular anastomosis happened. It's where the tissue was manipulated the most, where the primary closure was. It's where the original tumor bed meets this new transplanted tissue.
So if there was a little positive margin somewhere deep,
It's most likely to be right there, at that deep, surgically challenging margin adjacent to the native tissue.
which means the board-safe contouring rule is all about preventing a geographic miss.
100%. The rule is prioritize full coverage of the original resection bed AND, the flap native tissue interface.
Yeah.
You're not worried about the healthy fibula bone in the middle of the flap. You're worried about the millimeter boundary where that fibula connects to the residual native mandible and the soft tissue bed around it.
So this is where we avoid trap one, meticulously carving out the flap.
Exactly. The classic mistake is trying to draw a perfect line around the flap to save it from dose, only to realize you've created a cold junction right at the interface. You must extend your target volume into the flap, but only as much as you need to maintain full coverage of that interface. The extension is purely a strategy to prevent a geographic miss at the seam.
Let's use that construction analogy again, but really connect it to the risk.
Okay, think of the patient's head and neck as this major engineering project. It's undergoing extreme reconstruction. It's high-tension biology. The flap is the new material. It's relatively healthy. But the interface, that's the weld. It's where two very different materials are joined together under stress. If that weld is weak, the entire structure is going to fail.
And our radiation dose, specifically the 60 and 66 gray, that's our metaphorical high-strength weld.
Yes, and we have all seen the clinical consequence when that weld fails. It's not just a tumor recurrence. It can be a non-healing wound, a plate exposure, a chronic fistula. That junction is the absolute priority. This is where we use dose painting. The highest dose, the 66 gray, has to bathe that immediate surgical beta in the interface, but we aggressively pull the isodose lines away from the uninvolved parts of the flap to minimize unnecessary dose to healthy tissue. It's a very precise application of dose right where that seam is tightest.
Okay, moving from the soft tissue interface to the titanium beast itself. Our case has a significant titanium reconstruction plate holding that fibula in place. This introduces the twin problems of 1, contouring difficulty, and 2, dose calculation inaccuracy.
This is a massive challenge. I mean, the streak artifact created by the metal on the CT makes it almost impossible to rely on the image for contouring, and even more dangerously, for Hounsfield unit accuracy.
Let's go back to prevention. How does that metal artifact reduction, or M.A.R. algorithm, actually help us?
M.A.R. algorithms, which use iterative reconstruction or dual-energy CT, work by modeling the expected path of the X-ray beam as it goes through a high-density object like titanium. They then try to computationally subtract the predicted artifact from the image, filling in the gaps with estimated tissue data. It's an absolutely crucial first step. If your institution has M.A.R., you have to use it.
But some artifact always persists, right? Especially right at the edges of the plate. If the anatomy is just a blur, how do we contour?
This is exactly why the MRI fusion is mandatory. If the CT streak artifact is completely blocking your view of the mucosal contour just superior to the plate, you have to switch over to the MRI to infer where that true soft tissue border is. In areas of dense artifact, you should not be contouring based on what you see on the CT. You are using anatomic inference from the slices above and below, guided by the MRI.
Okay, what if our target volume, say our CTV60, unavoidably extends right into that region of hardware and artifact?
This brings us to the dose calculation pitfall. That dense artifact zone generates spurious, wildly incorrect Hounsfield units. We're talking density values that are thousands of units off from the true density of titanium or bone.
And the treatment planning system sees those numbers.
And it miscalculates the X-ray absorption. It leads to severe dose calculation errors. It can either dramatically overestimate or underestimate the dose that's actually being delivered to the adjacent tissue.
So we have to work really closely with our physics team here. What's the strategy to fix this dose error?
The solution is a density assignment strategy. First, the physics team uses the best M.A.R. reconstruction they can get. Second, they must deliberately contour the metal hardware, the plate itself, and assign it a reliable, known density value for titanium. They override the system. They don't let the spurious Hounsfield units dictate the calculation.
And what about the streaky areas right next to the plate?
In those adjacent streak zones, they may also need to override the density to a standardized value, like water or soft tissue density, just to ensure the calculation engine isn't thrown off by all that noise.
That sounds incredibly complex and time-consuming. What is the major planning pitfall to check for before we approve a plan like this?
The pitfall is accepting a plan where the Dmax, the calculated hotspot, is sitting directly in that artifact zone. If your plan says the Dmax is 110% of your prescription dose and is located right next to the plate in a high artifact area, you have to stop.
And question if it's real.
Exactly. You need your physicist to confirm, is this hotspot real, or is it just an artifact of the calculation system reacting to bad Hounsfield units? We call it a phantom hotspot, and you absolutely cannot approve a plan until you have confidence in the dose calculation in all of your target volumes, especially near that hardware.
So the goal isn't to eliminate the artifact, because we can't, but to have confidence that the dose calculation is accurate despite the artifact.
That's it perfectly. It requires specialized density overrides and careful verification, all while acknowledging that the planning system is being pushed to its limits by the metal.
All right, we have defined our volumes, we've managed the physics challenges. Now we have to face the hard truth of treating a T for a tumor that invaded bone. An unavoidable, significantly elevated risk of osteoradionecrosis, or O.R.N.
This is where clinical judgment really gets tested. We have to understand the O.R.N. risk framework. The core principle is that O.R.N is a composite risk. It's driven by high total dose, large irradiated bone volume, and patient-specific factors.
Can you elaborate a little on the mechanism of O.R.N? Because it's more than just bone cells dying from radiation,
Yes,
isn't it?
exactly. The old theory focused on the three H's: hypoxia, hypocellularity, and hypovascularity.
Huh.
But our modern understanding really emphasizes this radiation-induced fibroatrophic process.
What does that mean?
It means radiation damages the microvasculature and it activates fibroblasts, which leads to inflammation and then progressive fibrosis in the soft tissue and the bone marrow. This fibrosis impairs the bone's ability to remodel and repair itself after any microtrauma, which could be from a dental procedure or even just ill-fitting dentures.
And that helps explain why O.R.N can show up years after treatment.
Precisely. It's a chronic, progressive process. So for planning guidance, we turn to the dosimetry. The Kubota planning anchor from 2021 gives us a measurable risk gradient.
Tell us about that specific anchor point.
Kubota's data suggested that a mandible V60, the volume of the mandible receiving 60 gray or more greater than approximately 14%, was the point where the O.R.N rate really jumped. It went from about 3% up to 9% cumulative risk at 3 years. So it's a very useful tool to guide our optimization.
But you said it's a guide, not a hard constraint. How do we practically use that 14% V60 anchor in a case like ours, where the neomandible, the fibula, has to get 60 gray?
Right. So since our target includes the entire fibular free flap and the adjacent native mandible that was at risk, we know we're going to blow past that 14% V60 anchor. It's not even a question.
So what's the point of the number then?
We use it to guide optimization of the uninvolved portions of the mandible. We aggressively optimize our beam angles and our weights to pull those high isodose lines, the 60 gray line, laterally into the soft tissue part of the flap and away from any remaining uninvolved native mandible where possible. But the bone that is the target, the fibular flap in this case, is non-negotiable. It gets the dose.
Beyond the dosimetry, what are the most powerful patient risk factors that we need to be counseling our patients on?
The biggest one by far is dental extractions after radiation. That is a massive trigger for O.R.N. Continued tobacco and alcohol use are also major independent risk factors, along with just poor overall oral hygiene.
And there's some data about the timing of extractions before radiation, too.
Yes. The Newcastle data is important here. It showed higher O.R.N rates when extractions were done less than 31 days before starting radiation. The recommendation is to have at least 2 weeks, and ideally longer, for those extraction sites to heal completely before you start high-dose RT.
Okay, now for the moment of truth. The Accept and Counsel framework that helps us avoid board trap number 2. Given that our target coverage forces us to exceed all standard O.A.R constraints for the mandible, what is the wrong answer on an oral board exam?
The wrong answer is any compromise on the dose delivered to the CTV because of an O.R.N constraint. You absolutely cannot reduce the CTV 60 dose to, say, 54 gray just to meet a V60 target. That would be oncologic malpractice in a high-risk T4A PN3B setting.
But why not? I mean, why shouldn't we reduce the dose to prioritize long-term quality of life and prevent O.R.N, given we know the dose and risk are connected?
Because if the disease recurs due to inadequate dose, the patient has zero quality of life. In this scenario, target coverage takes priority over O.R.N constraints. It has to. Our job is to optimize aggressively to minimize dose outside the target. But if the target is bone, that bone must receive the prescription dose. We have to accept that this patient's O.R.N risk is inherently, unavoidably elevated.
So the correct clinical path is to accept the risk and then immediately move to robust counseling.
Exactly. You must counsel the patient explicitly about this elevated O.R.N risk, which in this case might be 20% or even higher. And for these reconstruction cases, you also have to counsel on the unique risks of plate exposure and chronic fistula formation. Both of those are high morbidity events that are unique to these hardware-based reconstructions.
In the final critical step in this framework.
Documentation. It is mandatory. Your plan note must explicitly state something like, Mandible V60 exceeds typical planning goals, which is unavoidable given target coverage requirements for T4, a disease with bone involvement. Patient was thoroughly counseled regarding the elevated risks of O.R.N, plate exposure, and potential fistula formation. This shows the examiner you understand the trade-off, you're prioritizing the target, and you're fulfilling your duty to inform the patient.
Let's talk about one of the major modern controversies in this field, the role of proton therapy. Does it offer a clear advantage in mitigating O.R.N risk in these complex oral cavity reconstruction cases?
It's a great question, and it's driven by the very intuitive appeal of the Bragg peak. The controversy is whether that theoretical advantage actually translates into reduced O.R.N. in clinical practice for this specific scenario.
Mechanistically, it seems like it should. The Bragg peak lets the dose drop off so sharply distal to the target. Shouldn't a proton plan be able to spare large volumes of the uninvolved posterior mandible or the contralateral side much better than IMRT?
Theoretically, yes. In a perfect world, in a static, homogeneous target, protons are fantastic at dose sculpting and posterior O.A.R. sparing. However, our patient presents three specific challenges that really complicate the use of protons: heterogeneity, mobility, and hardware.
Okay, let's break those down because I think they're often glossed over.
Okay, first, the fibular free flap is a highly heterogeneous target. It's got bone, which is high-density, soft tissue, and then titanium, which is an extreme density. Protons are exquisitely sensitive to density changes. The presence of that titanium plate introduces massive uncertainties in the dose calculation, and that could potentially lead to dangerous hot or cold spots right at that critical flap interface.
Okay, that's heterogeneity. What about mobility?
The oral cavity is a highly mobile target. The patient is swallowing, they're breathing. This creates something called the interplay effect. The high-dose scanning proton beam is vulnerable to this movement. If the patient swallows while a layer of dose is being delivered, the Bragg peak might land in a different location than we intended.
Whereas with an IMRT plan, that motion kind of averages out over the course of the treatment.
Exactly. With a proton plan, it can create significant geometric misses or hotspots right near the target boundary. It's a real concern.
And finally, the clinical evidence. Is there a consensus on whether protons reduce O.R.N?
The clinical evidence is decidedly mixed. Some retrospective series show similar, or in some cases even higher, O.R.N. rates with protons, particularly at the posterior ipsilateral mandible. This suggests that while protons might spare the uninvolved structures well, the high dose delivered to the CTV and all the uncertainties from density changes and motion may actually negate the O.R.N. benefit.
So what's the board-safe stance on using protons just to mitigate O.R.N. risk?
The concise board-safe stance is, do not choose protons solely to solve mandible or O.R.N. risk. The evidence does not clearly support lower O.R.N. rates for this specific indication. If you're going to use protons, it should be because you're achieving superior sparing of other critical O.R.s, like the brainstem or the spinal cord, not just the mandible.
Okay, let's shift to management. Let's say O.R.N. does develop in our patient down the line. How does it typically present?
It usually presents as persistent pain, trismus, and the most distinctive sign is exposed bone in the mouth that just fails to heal. Patients might also develop an infection or even an orocutaneous fistula.
And when does it usually show up?
The median onset is around 17 to 27 months after treatment, but it's really critical to remember it can happen many, many years later.
For early or mild O.R.N., we start with medical management, right?
Yes. The initial steps are conservative: meticulous oral hygiene, topical washes, systemic antibiotics if there's an infection. But the standard medical treatment is the combination therapy of pentoxifylline and tocopherol.
Can you detail the dosing and the mechanism for that?
Sure. The regimen is pentoxifylline, and that's pronounced pentox-IF-Ilene at 400 milligrams orally 2 or 3 times a day. And that's combined with tocopherol, which is vitamin E, at 1,000 units daily.
And how do they work together?
It's a great combination. Pentoxifylline improves red blood cell flexibility and microcirculation, and tocopherol is a powerful antioxidant. Together, they're thought to inhibit that persistent fibrotrophic process that the radiation started, which improves tissue oxygenation and remodeling. The treatment course is usually a minimum of 6 months.
Okay, what about the frequently debated role of hyperbaric oxygen, or HBO?
We have to be really specific about its role. For the prophylactic role, using HBO before dental extraction in an irradiated field, the definitive evidence comes from the HEPION trial.
And what did that show?
That trial showed no clear prophylactic benefit for preventing O.R.N. around dental procedures after radiation doses greater than 50 grays. So because of that, prophylactic HBO is not routinely recommended.
What about therapeutically for O.R.N. that's already established?
The evidence here is still a bit mixed, though it's generally more accepted when it's combined with surgery. Pooled data from trials like the Hansa 21 and the Northwest trial suggests there might be a benefit when HBO is used alongside surgical debridement compared to surgery alone, especially for more advanced disease. So it can be considered in some cases to help with healing, but it's not a magic bullet standalone therapy.
And if all the medical management fails?
Then surgical management becomes necessary. And this can range from a simple sequestrectomy, which is just removing the dead, necrotic piece of bone, all the way to, in the most severe cases, another segmental mandibulectomy with a brand new free flap reconstruction.
We've covered this case from pathology all the way through management of late effects. Let's try and consolidate the highest yield, most critical information that you need for immediate recall.
Okay, first clinical pearl has to be about geographic misavoidance. Cover bed plus interface, extend into flap to avoid cold junction.
Right. Always treat the seam. The resection bed and that area where the new tissue meets the native tissue, that is the zone of maximal risk. We extend the CTV-60 into the flap only to make sure that junction gets full coverage.
My next pearl is the staging principle. For oral cavity, NENE equals N3B.
This is the classic AJCC 8th edition staging trap. Pathologic extranodal extension overrides everything else, size, number, and immediately forces the staging to PN3B. If you see ENE on an oral cavity path report, you instantly know the stage and the need for chemoradiation.
Next up, the nuanced application of O.R.N data. V60 is a planning anchor, not a hard constraint.
We use the Kubota data, that V60 less than 14%, to guide our optimization. We try to minimize dose to uninvolved bone, but we have to recognize this data is retrospective and we never, ever sacrifice the required dose to the CTV-60 because of an O.A.R. constraint in a T4 case.
And that leads to the final pearl, the essential clinical decision framework. When bone is in the target, accepting counsel.
This just emphasizes that when the cancer dictates high dose to bone, like a T4 invasion or a neomandible target, an elevated O.R.N risk is simply unavoidable. Our duty then shifts, we optimize aggressively, we ensure target coverage, and then we have meticulous, documented counseling with the patient about O.R.N, plate exposure, and fistula risk. All right, let's run through 3 oral board style questions to really solidify these concepts.
I'm ready to test it.
Question 1 on flap contouring. A patient is post-composite resection for a T for a retromolar trigone cancer with a fibular-free flap. They need post-op RT. What is the correct target delineation approach for the flap? A, exclude the flap entirely since it's transplanted tissue. B, include the entire flap at the highest dose level. C, prioritize coverage of the resection bed and interface, extending into the flap as needed to avoid a cold junction. Or D, include the flap only if the surgeon placed clips at the interface.
Okay, the best answer there is C. Prioritize coverage of the resection bed and interface, extending into the flap as needed to avoid a cold junction. The core principle is covering that surgical seam. Excluding the flap, A, creates a cold junction. Including the whole flap, B, is unnecessary O.A.R. exposure. And clips, D, are helpful, but the anatomy dictates the contour, not the presence of clips.
Perfect. Question 2 on staging ENE. A floor of mouth patient has 3 positive ipsilateral nodes with ENE in one of those nodes. What is the correct pathologic end stage for this oral cavity primary? A, PN1, B, PN2AC, PN2B, or D, PN3B?
The correct answer is unequivocally D, N3B. For an oral cavity primary, the presence of any pathologic extranodal extension immediately upstages the disease to N3B under AJCC 8th edition guidelines, regardless of the node count or size. It's automatic upstage.
Final question on metal artifact management. A post-op oral cavity case has a reconstruction plate, and your physicist reports dose calculation concerns, specifically a phantom hotspot in the artifact zone. What is the appropriate response? A, accept the plan if target coverage goals are met, regardless of artifact. B, use MAR reconstructions and density assignment strategies with physics oversight, and avoid placing hotspots in regions with unreliable Hounsfield units. C, override the entire artifact region to air density to eliminate the uncertainty. Or D, exclude the artifact zone from all target volumes.
The correct clinical and physics-guided response is B. Use MAR reconstructions and density assignment strategies with physics oversight and avoid placing hotspots in regions with unreliable Hounsfield units. You have to actively manage the artifact. You use density overrides for the metal itself and the surrounding streaks to ensure your dose is reliable. Accepting the uncertainty, A, is unsafe. Excluding the target, D, is a geographic miss. And blindly overriding the density, C, is a physics error.
We've covered a really complex arc today, starting with that single most important staging point for oral cavity cancer, moving all the way through the practical challenges of planning a reconstruction, and ending with those clinical trade-offs for late effects.
Yet to just recap the most critical learning points. First, the PN3B rule for ENE in oral cavity is absolute. Second, when you're planning a flap, you have to prioritize the resection bed and the flap native tissue interface to prevent a geographic miss.
Third, managing metal artifact requires that multi-pronged approach. MAR acquisition, MRI fusion, and a very detailed collaboration with your physics team for density assignment to make sure you have dose confidence near that titanium hardware.
And fourth, when high dose to the mandible or the neomandible is oncologically required, you have to use the accept and counsel framework. Target coverage always takes priority over meeting an O.R.N constraint, but the patient must be explicitly informed of those heightened risks.
And finally, on the management side, knowing the limited role of prophylactic HBO thanks to O.P.O.N, and knowing the standard medical regimen for established O.R.N is pentoxifylline and tocopherol.
So for our 58-year-old patient with the T4A-PN3B fibular free flap reconstruction, the plan is locked. It's post-operative chemoradiation using that sub-approach, 66 gray to the E&E bed, 60 gray to the interface, and 54 gray to the elective neck, with very careful dose calculation verification and clear patient counseling on the risks.
That brings us to our final provocative thought for you to carry forward into your clinical practice. The risks of O.R.N, plate exposure, and chronic fistula aren't just acute concerns. They are lifelong surveillance issues. So given that, what specific systems, what cadence of dental and surgical follow-up, and what level of coordination must you establish to manage the lifelong risk profile of these complex reconstruction patients effectively over the next 2 decades? The complexity of the treatment demands a parallel complexity in long-term surveillance.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Radon Smart Review for our next episode.
Thanks for tuning in.